Welcome everyone to the webinar, Implant Success, Getting to the Root of the Matter. We are so glad you are here today to learn more about assessment and diagnosis of peri-implant conditions and the upcoming study from the National Dental PBRN. The Implant Registry study is the first national dental implant registry sponsored by the National Institutes of Health. And we are very glad to have today here with us, Dr. Nico Geurs. If you are not a member of the network, please do join the network. We will give you instructions on how to do that at the end of this presentation. We have a question and answer on the bottom of your Zoom that you can post your questions and Dr. Geurs will address them at the end. We will have ample time to do a Q&A with Dr. Geurs. So I would like to introduce you to Dr. Nico Geurs. He is our featured guest speaker, and he is the Weatherford Paucanis Endowed Professor and Chair of Periodontology at the University of Alabama at Birmingham. Of course, he's a periodontist, and he is the principal investigator of the Implant Registry study. His research interests include periodontitis and systemic health, regeneration, bone crafting, and dental implantology. And he has published and lectured extensively on these topics. We are very glad that he's now doing the Implant Registry study at the National Dental PBRN. Go ahead, Nico, it's with you now.
Thank you, Joanna, for the introduction, and thank you for the opportunity to speak about dental implant success. And what I want to do today is outline the parameters for success. And because of the short time I have available, I'm going to focus on the biological health and success of the implants. And then I will talk you through what I feel is important to understand about dental implants to be able to set up a successful dental implant restoration. In addition, I want the opportunity to explain the registry and how we are lacking knowledge to further advance our implant therapy and how you as a practitioner can contribute to the gaps in our knowledge. So first, I want to come back to implant success. And what you see here is a diagram of a tooth adjacent to an implant and with the various tissues surrounding a dental implant. If we look at successful dental implants and we look at the parameters that determine that success, often osseointegration is mentioned first. And osseointegration is critical for the success of a dental implant, but it involves tissue that is very predictable in how it responds to challenges and how it responds to healing. Bone and dental implants are meant to be together, and dental implants will be surrounded by bone if we put them in bone. Therefore, osseointegration is almost a given. And I want to come back to a little bit on the tooth side, because if you look at the tooth is surrounded by gingiva, and the function of gingiva is there to protect the attachment apparatus, to protect the bone, and to really protect the rest of the body from the challenges of the oral cavity. The tooth is very unique in its relationship with the gingiva in that nowhere else in the body does a relationship like that exist. Nowhere else do we have hard tissue sticking through soft tissue. And this happens to now be in the oral cavity, which is the perfect incubator for bacterial growth, and biofilm and bacterial accumulation tends to be easiest on the tooth surface because the tooth surface affords an opportunity to allow for biofilm to bond to the tooth. So this now creates a very important function of the gingiva to not only protect and seal around the tooth, but also to deal with microbial challenges. This is important because on an implant restoration, we have mucosa surrounding the implant, and that mucosa now has to perform that same function. So if you come back to the success of dental implants, for me, osseointegration, it must happen. And I don't want to underestimate that, but the fact that we can also create an environment around the neck of the implant restoration, where soft tissue performs those same functions in isolating out the oral cavity from the underlying tissues and protecting the underlying tissues from those challenges. So for me, the critical matter is that traversion through the soft tissue and creating an opportunity for the peri-implant mucosa to protect the implant. So then I want to look a little bit closer at this tissue. And again, here I have a contrasting image between a tooth situation and a dental implant. And what you see here is that around the tooth is surrounded by an epithelial attachment, and that's represented by the darker red tissue here, and a zone of connective tissue that's characterized by fibers inserting into the root surface. This now creates a zone of connective tissue supracrestal that is about a millimeter away from where the junctional epithelium stops. This zone here is where inflammation gets buffered if inflammation occurs around the tooth, and when you have gingivitis, and no effects on the bone are noted. Around the dental implant, our situation is slightly different. The junctional epithelium tends to come closer down to the bone, and the fibers tend to not be inserted into the implant or the abutment surface. They tend to run more parallel to it, creating a less dense or less wide of a zone of peri-implant connective tissue. And what you now also see is that that zone that is around the root, characterized by high vascularity, around an implant, that zone is somewhat void of vascularity. So what we really see here is a different type of tissue that surrounds it, but it's asked to do the same in our when in function. Those anatomical differences have an impact on what we would expect to find when we examine a dental implant. So rather than having fibers inserting into the implant surfaces, we have more or less a cuff that can be strong and can give resistance to this tissue, and that can seal around the implant, but it's not inserted into the implant. And therefore, the attachment to that implant is different, and when we probe, that resistance comes into play. What you see here is a diagram of what happens when you probe around a natural tooth, and it has two scenarios here. On the left side of your screen, you see a scenario where the probe is inserted into a diseased site. So what you see here is that the probe tip actually penetrates into the tissue because the integrity of the base of that tissue is not such to where it can withstand normal probing forces. In health, the probe tip stops short of that junctional epithelium, and now your probing depth measurement is very similar to the anatomical space of the pocket depth. Around a dental implant, there are no fibers inserting into the implant surface, and our probe tip tends to slide further down. Again, here you see a probe diagram inserted into a pocket that's around a natural tooth, with the fibers that insert into the tissues being somewhat of a firm tissue that will not be penetrated. Well, around the dental implant, the probe tip slides past that and tends to be closer in relationship with the bone and tends to not always follow the contours of the implant restoration. And that's a function of our implant restorations generally being slightly more over-contoured because the implant diameter isn't always matched up with the size of the implant restoration. The consequence of this is dual. One, that probing around a dental implant tends to overestimate the actual anatomical pocket. And it tends to penetrate into the tissue just slightly. And the difference is what you see here is that here we measure a shallow pocket, and here we measure a rather a little bit more exaggerated probing depth. And you may see this in your patients that are with a dental implant restoration and that are generally in good health, where you see regular 2 to 3 millimeter probing depths around the teeth, but the implant may have a 4 to 5 millimeter probing depth. and really don't exhibit any disease either. The other consequence is that because the probe tip tends to penetrate into the tissue, is that you get a small poking trauma. And that poking trauma now can exhibit itself in a pinpoint spot of bleeding on probing. And that pinpoint spot of bleeding on probing is now no longer an indicator of disease, but it could represent health. What you see here is a publication that looked at the 4 scenarios of disease or health that we can find around an implant when we probe. And one of them would be the scenario where we probe alongside the implant, not get bleeding, but and that represents health. But in a scenario where the crown is slightly over contoured, sometimes that probe tip leaves and exits out of the space right around the implant and penetrates into the tissue. And this now leads to a poking trauma. And that does give bleeding, but that bleeding is not associated with disease. What we're looking for in bleeding on probing around dental implants is more or less what we see when we see bleeding that occurs when we insert the probe and not delayed by about 30 to 45 seconds in the scenario B, but really when you insert it and probe and bleeding that wraps around the full implant. And then in peri-implantitis, we tend to have deepened probing depths with bone loss as well. So if we look at the bleeding that we are interested in finding, we're interested in finding bleeding that occurs when the probe is inserted and that wraps around that implant surface more or less like this, versus a small bleeding spot that's just occurring when where you insert the probe. So I talked about probing, and I think probing is important for us to understand, but probing depth measurements are different. What I'm mostly interested in when I probe is understanding the health of the gingival tissue, and bleeding on probing, particularly the one that I outlined on the slide before, where it wraps around the implant, is a sign of disease. And we also want to make sure that if there are no signs of disease, that we can establish health, because that is a great predictor of stability of that peri-implant condition. If we also look at probing depths, they are important to note because changes in that probing depth tend to indicate changes that occur around the implant and may be an indicator of bone loss. In addition to bleeding on probing, sometimes we see purulent exudate around an implant, and that you see right here. And purulent exudate tends to be a sign of more acute inflammation and tends to not be favorable for the outcomes of that implant, and that implant requires an intervention. Purulent exudate tends to not go away with just behavior modification. It needs a treatment intervention. So what you see here is a probe that has penetrated into that pocket for about 10 millimeters, and that now is associated with bone loss and a loss of supporting structures around the implant. And what now becomes very important is to understand what environment now is within that pocket. If we look at our dental implants, they're not all the same. They are different in configurations and they have many different shapes and sizes. And what I would advise you to do is be very familiar with the structures of the dental implants that you commonly see in your practice. Important features to understand is where are the threads located on an implant, because those threads can become part of that pocket environment and now require a different type of therapy. But it's also important to understand where the implant is roughened. So some of these implants like this one right here or this one right here are roughened all the way to the top, versus an implant like this one that has a machined color, or this tissue level implant that has also a machined color, where the transition of the implant restoration through the sulcus or the environment right at the apical extent of the pocket is a machined surface. And why is that so important? Because those roughened surfaces tend to look like this. They are a perfect place for bacteria to accumulate on, and they are associated with an inability inability of the surfaces to be cleansed by the patient's oral hygiene. So once these surfaces become part of that pocket environment, it is very challenging for that patient to be able to perform oral hygiene on those surfaces. So what we now have is the ability to clinically measure, but part of the problem with dental implant becomes that probing depths are very challenging to use alone in diagnosing whether or not an implant has disease. In addition to those clinical measurements, we always rely on radiographic evidence. And if we look at the radiographic evidence that is required for us to look at, it is always in relation to what we started out with. So in our clinics here, we have a protocol for the follow-up of our dental implants radiographically. And what we want to do is, of course, understand the early healing. So we take radiographs at the time of implant placement. We also do that when we take an impression to make sure the impression post is fully seated. We also do that when we take finally seat our abutments. But I find that for us, it is particularly important to have a baseline radiograph that forms a reference for that implant's healing and where the bone is at the time we put the restoration on. And that is taken once the final restoration is cemented, because it allows us to take a bite wing radiograph. A bite wing radiograph is the most optimal radiograph to position the radiograph parallel to the long axis of the implant and the X-ray beam perpendicular to that. That allows us to produce images with very good projection geometry. And on a dental implant, that's always easy to judge because you need to see nice, crisp threads on your radiograph. And this now serves as a baseline radiograph. We then follow up in the first year by taking an additional radiograph after 6 months, and then another one 6 months later. That's really at the 12-month time point. And that is because we want to detect early changes to the restoration so we can intervene with early disease if it were to occur. Thereafter, we take annual radiographs, and that is for our implant restorations because we feel that probing depths alone aren't always going to tell us the full story. So what we now can end up with is sometimes we have an implant that is platform switched, for instance. This platform switching makes probing a little bit more challenging. The neck of the implant restoration tends to be narrow, and the platform of the actual implant will prevent the probe dip from really following the implant surface. So sometimes it becomes very challenging to evaluate whether or not implant disease has occurred by probing alone. So we complement that exam with that dental radiograph. So what we now have is a combination of the clinical examination, the determination whether or not the soft tissue is healthy, whether or not we have bleeding on probing or suppuration, together with the radiographic evaluation. And those parameters now guide us in our diagnosis of peri-implant diseases. And I use a simplified form of that in that when we assess a dental implant, determine whether or not we have inflammation by bleeding on probing or suppuration. And we now look at whether or not we have radiographic bone loss. If we have no inflammation around the implant, we determine that to be health. If we have inflammation, we now distinguish on the radiographs whether or not we have bone loss or not. And if we have bone loss, we diagnose the implant to have peri-implantitis, which is disease that includes bone loss. And if we don't have inflammation, we call that peri-implant mucositis. So health, of course, is characterized by healthy tissues, and then histologically, we don't see inflammation. So this is to me, a rather simple diagnosis to make, but it does involve inspecting that peri-implant tissue. And for me, probing is important. If we end up having bleeding on probing, but we do not note bone loss on the image, we have peri-implant mucositis. And peri-implant mucositis differs a little bit from gingivitis in that it can occur earlier on in the process and tends to be somewhat more resistant to therapy. So if you treat peri-implant mucositis, it may not resolve as quickly as gingivitis does when we expose that to treatment. And what we also see is a rather more inflammatory rich tissue that surrounds that peri-implant zone in peri-implant mucositis. If we then look at the ugly cousin of peri-implant mucositis and we look at peri-implantitis, that now is characterized by inflammation. It tends to be more exaggerated in the way that clinically presents. It doesn't always have to look like this, but this is an example of what that could look like. And then if we look at the radiographic picture here, we also see bone loss. And these are not the exact same case, but we see bone loss around the implant. And then if we flap that back, we can see that this is a circumferential defect. So if we look at peri-implantitis, it does include probing depth measurements combined with the evidence of having bone loss occur, because early on I already said that sometimes probing depths may be deeper without bone loss just because of the way we probe and the way the attachment's structured around the implants. Okay, so peri-implantitis, again, characterized by those deeper probing depths, and we now also include into that our radiographic picture, and that is, I'm not sure why my radiograph's not showing up, but here's another example of that. So here we see the bone loss that has occurred, and it's very important to interpret these radiographs correctly. I know my pointer is not very easy to see, but if you look at this implant, it is very obvious to my eyes that we have about 6 to 7 millimeters of bone loss around this implant. And my knowledge of peri-implant bone loss is strengthened by the fact that I also surgically treat these. So not only do I look at the clinical picture, the radiographic picture, but I can also look at the surgical picture. That's what you see on the right side of this image, where you see the bone and the defect around the implant without the soft tissue covering it. So having this knowledge and then looping that back to the implant restoration is important. Now, if we look at the etiology of this disease, it tends to be pretty straightforward. It tends to be inflammation that is caused by biofilm that leads to a host response, and that biofilm is inherently not much different from what we see around teeth. It is the same complexes of bacteria we see. Sometimes the attachment's a little different, and just like in periodontitis, biofilm forms differently on a pristine tooth surface than biofilm formed on a root surface, then biofilm that is formed on a root surface that is covered in calculus. A pristine tooth surface requires the attachment of the bacteria that are very good at attaching to those surfaces, the blue, purple, green, and yellow complexes, before the bad guys for periodontitis can come into play. If calculus is there, that requirement somewhat goes away, and it can exist in a flora that may be void of some of these early colonizers, or it may not be critical for them to be there because the orange and red complex bacteria can harbor just on that calculus aspect. And that same can be true for those implant surfaces that are exposed because they are roughened. And I showed you those pictures earlier where those surfaces are very similar in what they look like. So now if we look at the parameters to set up peri-implant health, it is also very important to determine the other etiological factors that play a role in disease. Excess cement remnants are certainly part of that. The prosthetic fit of the restoration are part of that. The location of the microgap are part of the implant success. whether or not you have loose abutment screws or over-contouring restorations, or the lack of keratinized tissue. All of those parameters are kind of associated back to the first thing I talked about that was critical for implant success, and that is that soft tissue zone, because all of these parameters I just listed interfere with that zone performing that seal function. They are kind of in that sulcus environment and allow the bacteria to take over and dominate that scene versus nice, healthy tissue that is dense around the implant. The other factors are somewhat obvious as well. Implant fractures are generally not good for the implant success. Surgical trauma tends to be an issue. Calculus and systemic disease can also influence implant disease. In addition to those factors, I think it's also important that planning our implant restorations for success is very important. So not just place the implant where possible, but place them where they are prosthetically required. And in my mind, implant dentistry is a combination of surgical success followed by prosthetic success. And that now is done in unison with the final outcomes driving our implant planning. For me, an implant is set up for success by the right surgery. And in that, the surgery determines the prosthetic success. But it is really the prosthesis and how it traverses through the tissue that determines the soft tissue health. So, and that to me is sometimes a shift in thinking, in that when inflammation occurs around a restoration, it tends to be sent back to me as the periodontist to fix, but often the fix is prosthetic. So that now brings us to implant success. We are very successful with our dental implants, and implants are the most successful implant in medicine. And often do we have scenarios like this where we have an implant surrounded by healthy tissues that lead to a aesthetic, functional restoration that is surrounded by health, and that can be maintained as such. So these are all the cases we are very excited about. We, however, also have biologic and prosthetic complications, and those occur and can be interfering with the happiness of the patient. They tend to interfere with the performance of the implant restoration, and that can now have an effect on the happiness of the practitioners. So we can distinguish biologic and prosthetic complications, and we still have these occur on a, as reported in the literature, relatively regular basis. That brings us to the registry, because the registry is an effort that we have undertaken with our team to understand what therapies are provided in practice. And what we're aiming to do with this registry is to create an opportunity for us to record the setting of implant therapy and what implants are used, what prosthetic therapies are provided, but also to understand what parameters are associated with implant success. And that is both in biologics, but also in prosthetics. And then we want to make sure we understand when biologic and prosthetic complications occur, so we can better assess risk factors in the future. And if we can do so, we can come up with better strategies to prevent these implant complications from occurring. So this is where we need your help. This is where we are very excited to be able to interface with you today, but also to be part of the network, so we can recruit practitioners to be part of this study and to contribute to that generalizable knowledge that will make the implant therapy in the future better. So what we are aiming to do with the registry is to create an observational 3-year cohort study in which we are going to recruit practitioners who restore dental implants. This registry starts with the implant restoration as it is placed, and we are going to document the exact circumstances that occurred when the implant was placed, and we'll make sure we understand how that implant performs over the years. So we're looking for approximately 200 practitioners in each region of the country, and we're looking for practitioners that can contribute approximately 10 patients with a total of approximately 50 implants. Those numbers are approximately because they're not hard, and we want you as a restorative dentist that restores dental implants to be part of this. The patients we're looking for is approximately 800 patients, and the patients will then also have some incentive to participate because we will reimburse them for their contributions to the implant registry. The data collection is, in my mind, relatively simple. What we have designed is surveys that can be filled out on any web-based device, and those surveys will be given to you when you enroll a patient. The patient will also get their baseline surveys, and the patient's information we gather are mostly related to their health history, their health status, but also to their current oral health satisfaction. So we do that at baseline prior to the restoration, and then we follow that up for the 3 years, and the surveys are customized to the implant restoration that you have indicated that you have restored. In addition to those surveys, we want a radiograph that's taken at the time of insertion of the prosthesis and then digitally submitted to us each year at the follow-up visit. So we want annual follow-up visits and radiographs that represent that. We've designed our surveys to be in harmony with what I think is a reasonable burden for the study. So we don't want this to be something that will take you away from your regular care. We want this to be something that is part of what you do and part of the data that you already collect on your implant patients is what we're going to ask for in these surveys. So again, the data we are looking for is the baseline characteristics of the patient. What type of occlusion do they have? What other teeth are present? What type of prosthesis are we inserting? And what are the mucosal characteristics? And at the annual review, there will be a specific survey based again on the prosthesis that you have indicated. As a practitioner, we will remunerate you for your efforts, and that is $40 for each implant rolled for the submission of all that baseline data. The burden at that visit is a little larger than at the follow-up visits. And the follow-up visits are remunerated at $25 per implant. And that is a per implant because we gather information per implant. So if a patient has 2 or 3 implants that are part of the same prosthesis, that will then occur a remuneration for each of those individual implants. The patients will get remunerated for their efforts, and they will get $25 for every time they complete the surveys. They're asked to fill out a baseline survey that captures their health history and their habits. And at the follow-up visits, they'll get a specific follow-up survey as well. And once completed, they will get those payments processed. And it'll be a payment that will be generated following the completion of each of those visits. So as you may be able to tell, I'm very excited about the opportunity to interface with the network for this registry. And I'm very excited about the opportunity to work with you as a practitioner, and very excited about the opportunity to generate new knowledge that is novel for the United States and really novel for the world in a real-time practice setting, and we certainly need your help. Thank you so much for the opportunity to speak to you today, and I will be available for question and answers. And the best way to ask your questions is through the question and answer box, and it's a simple type in. It can be done anonymous as well.
Thank you, Nico, for a great presentation. I have a first question for you, and I think Smitra can help us with any Q&A. Please do post your question on the bottom. There is a Q&A button, and there is also a chat. So please, if possible, use the Q&A, not the chat box. I just wanted to highlight that if you are not a member of the network, please join us. Nico, can you post the next slide so that people know how to join? And also, if you want the CE credit, there will be a survey when we finish today that you need to answer so that we make sure that you receive your CE credit. You need to be a member to receive the CE credit. Nico, my first question is, why are you doing this study? What do you expect to get from it once you have 3 years from now, when you have results?
Okay, so why do we do this study? So most of our implant data is generated in what I call atypical environments. It's generated at university centers with atypical patients, and a lot of that is now translated into practice. And we've learned from some of the community-based research that doesn't always work exactly the same. So what we're trying to get to is the performance of dental implants in the various restorations in that practice setting, the way you treat your patients and the way you are documenting those cases as well. So for me, the value of that information is that the information we gather directly translates back to opportunities to improve that practice setting. What we hope to be able to identify is very specific risk factors that may be related to a certain type of prosthesis, a certain type of implant scenario or situation, maybe even a certain type of implant type associated with a restoration that we know is high risk. And therefore, we can inform practitioners to not perform that therapy. And we also like to identify the therapies that work with low risk for complications and inform you as a practicing community about that as well.
Great, thank you. Shimitra, do we have questions from the Q&A?
Yes, we have a lot of questions. So our first question is, can school faculty practices able to participate in the study?
So the practitioners we would like to recruit are practitioners that have a long-term relationship with their patients and that perform restorative implant therapy. So if that's you in a faculty practice environment, we would encourage you to enroll. And what we want to create is the opportunity to gather this data longitudinally for at least the 3 years that are designed within the current funding mechanism. It is our intent to continue this registry, and we will use the data that we gather during our first years of the registry to make an argument that this is very important and that it should receive additional funding. So it's not a registry that I intend for these 3 years, but what we're doing is here creating a baseline registry that's robust, is meaningful, and that will warrant extending out beyond that. But we're looking for practitioners that perform restorative therapy and have a long-term relationship and are willing to contribute to these, to our data by the annual surveys, by proper baseline data gathering, as well as those annual radiographs, because they are for us very important. And the radiographs have to be of high quality, but we know from previous studies that that tends to be the case in the network.
Yes, because that was a question that a surgeon wanted to know who places implants, if he could be in the study, but they don't place the final restoration. He says he follows the patients and could follow them for 3 years.
Most of our survey questions are related to both the peri-implant environment as well as the prosthesis. So that's the knowledge that we need to be able to gather. We do gather surgical data, but mostly retrospective. And the reason we picked the prosthetic placement as our time to start the registry is that in addition to the studies being in a university setting, most of our data tends to be about the surgical placement, the early healing, and then the transition into a prosthesis, and long-term performance of implants, both from a biologic as well as a prosthetic perspective, aren't always available. So we didn't want to duplicate that first year of healing implant surgical placement and the wound healing associated with that. We really wanted to look at how these implants perform once they are restored. So if that opportunity exists in your practice, then you could be part of that registry.
Okay, another question we have is, what is your guess about what percentage of complications are biologic and what percentage are prosthetic?
So if we look at the literature right now, the amount of complications, if we look at the percent of the complications, the overall percent, the prosthetic complications tend to be more prevalent than the biologic complications. But if we look at studies long-term, and they tend to be a little longer than the 3-year study we currently have, the amount of biologic complications could range somewhere between 26 and 88% of the implants. And it depends a little bit on the definitions you use. So biologic complications are common, and particularly in peri-implantitis tend to be grave. It's hard to treat. Prosthetic complications tend to include screw loosening, tend to include porcelain fractures, and sometimes they are repairable, but they can be a nuisance to the patient and can interfere with their perception of success as well. So we do expect complications, and we want to find out what time in that restoration do they occur. So if we know that some complications do not occur in the first year, but start to accumulate later on, we can start to look at trace back to that initial therapy and what we potentially could do at that point to prevent those more later complications.
Okay, the next two questions are about timelines. The first question is, how will there be a longer study follow-up at 5, 6, 7, 8 years? And then I guess the predecessor to that question is, how is the timeline? When is the project starting? So I kind of combine those two.
Both are very good questions. So I already indicated that we are interested in the long-term follow-up. So we will seek an opportunity to extend out this registry and get funding for that extended registry. And we hope to do so very early on in our once we have preliminary data, or we have data from this registry, to be able to make an argument that that should be done. And I'm very convinced that we can get to that. The other question is, when will you be able to enroll in the registry? We are looking to launch the registry this July. It depends a little bit on the different regions when you can enroll, but we are looking at enrolling in from July on. And I would seek an opportunity within your region with your node coordinators to find out what the status of that is, if you're very eager to enroll. Enrollment timeline is somewhat tight, but we're working to be very efficient and making it very easy for you to participate in this study. And therefore, we hope to be able to meet our enrollment goals.
Just to add to that, node coordinators are sending out recruitment materials maybe over the next few months to looking for practitioners interested in the study. So please respond to that on those calls as well. The next question, would you be recruiting providers or practices? For example, a provider that restores implants at 2 different practices.
So no, that provider can enroll their subjects at both locations. So the provider is enrolled, and the provider now enrolls their patients into the study. So the location where that occurs, to me, is not as important, as long as we can capture all the data associated with the therapy. So it's the provider that's enrolled. I'm very encouraged by the type of questioning, because from the questions, I can sense there's some enthusiasm in participating in the study, and that's of course what we're interested in.
Nico, can you walk us through a practitioner that decides to do a study? What are the steps when they see a patient that's placing an implant prosthesis? What happens then?
Yeah, and I will pick up that scenario from the point that you are an enrolled practitioner within the study. So what you would then do is identify patients that have their implants ready to be restored, and then have a conversation with the patient about participating in the study. The burden for the patient is relatively low. We're going to send them a web-based survey that they can complete on a web-enabled device, and they basically have to answer questions about their health history, their habits, and their perception of their oral health, quality of life. And then once that subject is recruited, at the time of prosthesis placement, we want you then to collect your baseline data. And that baseline data, again, includes the location of the implants. It includes the type of implant. It includes the prosthesis provided in great detail. These surveys are now smart surveys, in that if you have a removable prosthesis, you'll be directed to a different set of questions than if this is a fixed prosthesis. And at the follow-up surveys, that knowledge about the prosthesis is retained. And so the questions you get asked at the follow-up surveys, again, are now specific to that implant restoration and the implant that you have reported at baseline. So the data preferably is collected chairside, but if you have good dental records, you could potentially record your regular implant examinations and complete those surveys after the patient has left. We want this to be one that fits within the flow of your practice, and our surveys, to me, are streamlined to not take you away from that very much.
Thank you, Nico. Nico, can you